I think we're live here. I think this is working. I don't know. I need a sign of life. Things are going to be a little bit different tonight because we're out of the studio and we're back in the home office, which is going to make it a little bit different tonight. As always, hope the technology works. We are actually doing a Zoom call with a number of participants, and then we're streaming it out to the world. So before we begin, let me give a quick overview of what we're going to do. Chat away in the chat room. Ask questions there. We're going to have people in the chat room. Vanessa and Jan are in there. I think right now maybe Heidi James is in there. And they'll be sending me some of your feedback and questions you might want answered. Obviously, New York is in the thick of things. And the way we want to do tonight is first I want to get Swami in and talk about what's happening on the front lines. He's got some very important guests that he wants to introduce you to. I should also say that Sarah Krager couldn't make it tonight. Unfortunately, she's intubated about 20 million people and is herself a little sick right now, but she says, don't worry, she's doing fine. And then we're going to talk with Dave Talan about some really interesting things about just how infectious is this, what we've learned from Singapore in particular, and a little bit about IgG testing. And then we're going to talk to our critical care people about how to tube, when to tube, non-invasive ventilation, and this kind of stuff. So Swami, you can unmute yourself. And how are you, mate?
I'm doing okay so far. Unlike our two guests that we're going to be bringing on, I don't yet have COVID-19.
Excellent. Well, you know, we watch CNN, we watch all the shows, and they do lots of great shots from outside the hospital. But I'm just looking at like, can you just go into the ER? I want to see what my people are doing. So can you give us a sense right now of how bad it is where you are? Are you in the worst place? And just give us that color commentary.
Yeah, so I'm working in an ED across the river from New York. So I'm in Jersey and we are just starting to feel the surge. We're just starting to get hit. And I'll tell you that we're already running low on ventilators, on PPE. We're starting to run low on beds in the hospital, ICU beds. And I don't think that we've really felt the surge yet. I think we're a little bit behind where New York is, and we're already feeling a pinch.
So I'm going to let you take over for a little while here, Swami, and talk to our very special guests who are in fact infected. And what does that feel like?
Yeah, so we have two guests with us, Dara Kass and Jenny Beck-Esmay, both of whom work in New York City, in Manhattan, at emergency departments there. I've worked with both of these women in the past. They are fantastic physicians. And unfortunately, both are under quarantine currently because they are both COVID-19 positive. And I wanted to talk to you guys a little bit about what's going on, but first let's introduce you and bring you on the program. So say hi to everybody.
Hi, everybody.
So Dara, you have now been positive for 9 days, 10 days?
So I'm day 10 of symptoms. Actually, symptoms are resolved today, and we can talk a little bit about the resolution of symptoms and what that feels like to declare yourself COVID case closed, as I've decided today I am. I started having symptoms on Monday, 2 days after. I worked in the ER with patients that we were calling respiratory rule-outs, is what we called it, where we had a lot of kind of patients who were short of breath, some coughing, some fevers, but most that were going to go home. And I was using PPE, and here I am, tested positive, started having symptoms 2 days later. We'll go through that, I think, a little bit together. Went actually registered as a patient myself for a virtual urgent care visit, got an appointment, got a test ordered, went as an outpatient to get tested. So 4 days after onset of symptoms, I found out that I was COVID detected, is how they tell you in your results. And that was actually 6 days ago. So now I'm 10 days from the onset of symptoms, and I think that my course is resolved, thank God.
And even in 10 days, Dara, the conversation has changed so much. 10 days ago, we were saying these are respiratory illness. Now, if you come in with a respiratory complaint, we're calling them all COVID-19. So even in the 10 days that you've had symptoms, it's really changed dramatically.
It's overwhelmed our hospital systems right now. I would say that 75 to 80% of all the patients at all of our EDs are at least being ruled out for COVID, but certainly coming out with symptoms consistent with that infection right now.
And I would also...
Did you guys start with? Yeah, Jenny.
I just want to add, patients who you don't think are coming in with symptoms, your trauma patients, your stroke patients, are turning out to also be COVID positive. So the little old ladies who are falling down with hip fractures are COVID positive. So just kind of assume that everybody is for the time being.
And so I know both of you aren't working right now, but Jenny, how did that change what you were doing when you were working from 10 days ago, when if you had cough and fever, we were saying, okay, we're worried, to the idea that everyone coming in has it?
It's changed generally in that people are just wearing the PPE as much as they can all the time. At the beginning, we were able to isolate these patients. They would go into rooms by themselves. We would talk to them via telehealth over the phone. But as it's picked up and as we've realized that the symptoms are much more broad than we initially anticipated, we're just assuming we're on high guard at all times and wearing the appropriate PPE at all times.
And what are your hospitals seeing in terms of volumes right now? Just overall volumes, not just the COVID-19 volume.
So it's funny. Most of us have worked during natural disasters and kind of unnatural disasters, and there's usually a calm before the storm, right? So you get out all the unnecessary patients or the patients that you think could be early discharged, or you get them out to like their home or nursing homes or wherever they're going, and it feels eerily calm. And I think that like maybe 10 days ago, that's what it felt like in New York City, that we'd really gotten out a lot of the patients to make room for the patients. And now we're starting to see it fill up again and again. And I think the way I describe it, it's like an increasing pressure valve. And you see that, increasing patient who 9 days ago was a walking respiratory patient that could easily walk, 10 feet and felt like they could be discharged. And now they're more tachycardic and they're more hypoxic. And you see the course of disease really progress in the patients you're seeing. You're seeing younger patients come in needing to have oxygen support and getting ventilated. And so you watch your ER start to fill up now, like the calm before the storm is over. And now we're really heading into the hurricane.
Are your overall ED volumes much higher than they were before all of this hit, or they're about the same? And it's just the percentage of patients with COVID-19 that have changed?
Jen, so at RER, we're about 75% of our normal ED volume that we were before, but we're probably at a good 100% capacity as far as critically ill patients. I think that the number of notifications, intubations, isolation patients is so much higher than it was even 2 weeks ago. So if we were holding 180, 200 patients at any one time, and now we're at 150, but those 150 are now representatively more sick than they were before. That's at least my experience in general.
Yeah.
Jenny, how about your hospitals?
Yeah, mine's all anecdotal. I don't have the specific numbers. It's kind of interesting. I feel like I'm watching the surge move from east to west, or like east and north and down and over. So it seems like it's hitting Brooklyn and Queens and northern Manhattan and the Bronx the hardest right now. And now it's kind of moving its way into eastern Manhattan, and it's kind of going to move its way across Manhattan and eventually over to you in New Jersey. So I would say our volume across the board is just generally down. But yes, we're seeing a huge uptick in respiratory illnesses, a huge uptick in hypoxia, a huge uptick in COVID, obviously.
And what about your resources? We know that everyone's short on PPE. What about ventilators? Do you guys have ventilators in your hospital? Where are you with that?
So I think that we're all okay for now. I think Jenny's making an accurate reflection of what's happening all over New York City. The governor of New York City, I think the governor of New York State has been remarkable in his leadership, to say the least. But he's calling for 30,000 more ventilators through all of New York State. None of us have ever thought about the need to have 30,000 ventilators, an increase in 30,000 ventilators in our single state. And so I think that we're getting a little bit of encouraging data on the flattening a little bit of the effect in New York and the number of doubling patients we're seeing, from Sunday to Monday to Tuesday, as far as hospital admissions go. But we're going to the projections say that we're going to hit critical mass of our surge ventilators and bed capacity within 2 weeks.
2 weeks. What can we do? So you're right. New York has been hit first in the US in many ways. Obviously, Seattle had a big hit a little bit earlier than we did. What can the places who haven't seen the surge do that maybe your hospitals didn't do or didn't do fast enough that they could prepare now for that incoming wave? Preparing for the ventilators and preparing for the PPE and all of the equipment is obviously huge. I think there's a few areas that kind of have a tendency to go unnoticed because they're patient populations that go unnoticed. And that's figuring out now ahead of time what you're going to do with your homeless patients who are COVID rule-outs or COVID positive, who are well enough to be discharged, don't need to take a hospital bed, but don't have a safe place to isolate. Similarly, your prisoners, any patient who's in custody, you don't necessarily need to keep them if they're well enough to go, but you need to have a safe place to send them. And so get that plan in place now rather than chase it. So our city, unfortunately, has been kind of chasing that plan.
I will also add, start thinking about innovative ways to take care of patients in a humane way. And I think that that's something that's been kind of we've been seeing that quickly. So we've all been using telemedicine in new ways, which is remarkable. And I think think that offering telemedicine services to your patients who can stay home, but still feel supported and have them understand when to come in. But I think that in the very first onset, and especially with the PPE, the shortage of PPE, we started seeing using telemedicine in the place of compassionate care. And we need to figure out a way to deliver compassionate care to patients that are either being isolated shouldn't have happened, that need to be isolated, or that are that somehow we need to figure out how to take care of them in a way that is using innovation, but not sacrificing their patient care.
The telemedicine thing is really interesting, Dara. Have either of you guys had situations where you have patients, we're seeing a lot of patients that come in, they look pretty good, but we know that these patients can decompensate fairly rapidly. And so we're sending them home. Have any of you been setting up follow-up by telemedicine just to check in and see if they're still doing well?
So I do a lot of telemedicine, actually. And so this is something that I've actually been able to watch the progression of from patients from home, which is a super unique experience as an emergency medicine provider, because I'm able to watch the patients from the ER come in and watch the course of disease. And what I can say is it's identifying those patients and saying to them, please call back. So if it's making sure that if they're on day 6 or 7 of disease and they have the fevers of 102, 103, they're starting to get progressively short of breath as an outpatient, walking from their bedroom to their bathroom, you basically give them a permission to call you back anytime they need. Now telemedicine is covered by a lot of these legislative acts supporting this, and you make them walk it home, right? You ask them to go on Amazon and buy a pulse ox. They show you the data. I've sent patients to the ER sitting at 92% with heart rates of 125 that have literally pulled up a finger and said, see doc, this is my pulse ox. This is what it's showing me. It's really a way to integrate the best way of outpatient care with the emergency care that we're seeing on the ground, but still keep patients out of the ER as long as we can.
Jenny, with the current PPE shortages that we know we have, when you got sick or the days leading up to you getting sick, were you already having to sacrifice proper PPE when seeing patients? Were you guys already at the point of reusing PPE? Where were you in that process?
No, we're not at that point now. Even we're not sacrificing anything, which I feel grateful for. I'm one of the people who generally likes to wear a surgical mask for seeing all respiratory illnesses, even before coronavirus was an issue. So I honestly have no idea where I could have gotten this, whether this was from a patient or from the subway or from the grocery store community spread, because I think I was pretty careful with PPE from the start.
I think this is one of the really tricky things in New York City. You guys will attest to this. You can't stay 6 feet away from anybody. In fact, even when you're in your apartment, you're probably within 6 feet of 4 or 5 other people who are not in your physical apartment at that time.
Right. Yes, absolutely.
And we're actually seeing this very interesting thing in New York City about residents and faculty living in apartment buildings, and what their apartment buildings are saying to them about entering the building, how they decontaminate before they get, they are not allowed to go to the laundry room, that they have to walk hallways quietly, quickly, and not speak to anybody. And so there's this kind of downstream effect of the concentrated living we have in New York City, and what that means, not just for patients, but for providers, and what that means supporting those providers as they care for these patients over the next, weeks and months. And it may mean making sure that we have housing for providers to stay away from their families and out of their houses so that they can actually live a little more freely than they can even in their own homes.
So let me tell you guys what I have read about over the last 24 hours as to reusing my PPE. I can bake it. I can UV light it. If I can get enough ozone through that PPE, I can reuse it. Have you guys had to do any of these things or have discussions about these in your hospitals?
So I have a lively attending group chat, and everyone's talking about those various options because we're foreseeing them being possible. I mean, all of our institutions across the board, I know are doing their best to get the proper PPE. Nobody's trying to not get it. But it might come the day that we're doing that. A friend of mine did try baking his yesterday. The little elastic straps did not melt. So that is good to know. We might all be baking our N95s pretty soon.
I will say that this idea of using bandanas, even these homemade masks, I mean, we saw an onslaught of regular people asking me, should I just start sewing? And I'm like, not for us. we really appreciate the gesture, but that's not what we need for healthcare providers, right? So we need to make sure that the supply chain is open. I will say I'm super proud of one of the grassroots efforts, the getusppe.org, which is really a bunch of healthcare providers all over the country helping to actually create the supply chain, matching the demand with the supply to get doctors all over the country, and centralizing that in a way that's not just like the Hunger Games of competition, where Mount Sinai, where Jenny works, and Columbia, where I work, are fighting to get boxes of masks for our providers, because it's not about choosing which one of us gets protected. It's making sure that all of us, and when we're done in New York and we have it, go down, that there's availability for you in New Jersey. We New Yorkers need to be there for New Jersey in a way that we generally aren't, when it comes to the PPE availability, and making sure that those ventilators are freed up and that supply chain is freed up so that we're all protected.
All right, Dara, Jenny, thank you guys so much for coming on and doing this. I know that all of our listeners out there are hoping that you guys, well, we're happy that you guys look pretty good right now, that the symptoms, Dara, for you are starting to resolve. Jenny, I know you've been toughing through this, and we really are appreciative to hear what you guys are seeing, what you guys are experiencing. I'm sure we'll get lots of questions. We'll get them over to you guys. I hope you both feel better soon. Can't wait to see you back out on the front lines. Remember, once you have immunity, we expect you to be on that frontline team doing all those airways so that the rest of us don't have to worry about it.
Donating plasma. We're going to be donating
I signed up
plasma
this morning. I did. I'm like, take my blood, please.
All right, guys, stick around. I know Dave has a couple of questions for you, but I'm going to turn it back over to Mel so he can carry on with the day.
Thanks, Swami. I want to do a little switching here. I want to show you a few resources. Let me see if I can make this work without screwing the whole thing up. Let's see. So I want to remind people before I start talking to Dave, EMRAP, we've got lots of breaking news. We just had a Right on Prime one that came through on the textbook front. Obviously, under the COVID section, we are updating this chapter very, very frequently, like daily. And we'll put in the stuff about baking your personal protective equipment. We'll have to find some science behind that first. People are saying like 70 degrees for 30 minutes is what some people are using. But we'll get some actual sort of facts on that. There's another thing I want to show you on this slide, which is we're trying to create some videos where basically we have healthcare workers, saying stay home if you're not sick, stay home if you're not sick, and correlating them, getting them all those together, and then doing it as a public service sort of announcement kind of thing. And if you'd like to play in that, that would be great. There's, I think, at the bottom of the YouTube thing, a how-to thing there. And I just crashed. I just crashed. God help me. You might be still hearing this.
Well, Mel is getting back online. We did have a question in the chat, and since I still have Dara and Jenny here, I don't know if you guys have the answer to this. I'm not sure I do. Dave might, though. Dave, if you are listening to this, if you have an answer, if you get the virus and recover, so that's the situation that Dara is currently in right now, do you still need to wear a PPE at work?
Yeah, I don't think we know the answer yet for SARS-CoV-2. So a recent study came out, and it showed that individuals infected with COVID-19 first developed, as one would expect, with an infection where humoral immunity is important in the response. First, there was a very consistent rise in IgM, and then after about a week, you started to see IgG. And IgG is what we believe is protective against the next infection, but not all infections, once you recover from them, lead to lifelong immunity. Certainly, we believe that, for example, convalescent serum, which remember me, you guys, when I need it, okay, please. We think there's pretty good evidence that convalescent serum, either before an infection like this or very early on, may be helpful. But nobody knows. Nobody knows if a person, once they get infected and recover, and you can measure their IgG like this study suggests, if you're protected, if you're fully protected, or if you will have protection and that will wane. So, for some infections like measles, once you get that measles, you will not get measles again. But for other infections, for example, Swami, maybe you know, or I guess I should say, maybe you've read that if you get syphilis, you can get it again, right? So
I'm not sure what you're insinuating, Dave, but let's carry on.
well, that you might have tertiary syphilis, you know. And there's IgG after the initial infection. And then for flu, you know, the virus can change. So, you know, we talk about antigenic drift and then shift. And so that can leave populations either unprotected or with partial immunity, like we saw in 2009 with the H1N1 swine flu. Remember, older people didn't get the infection as much, and when they got it, it wasn't as severe. So sometimes what happens over time is that there's some immunity and there can be partial immunity. So I would guess, and I don't know, that our friends here are protected in the short term. I would imagine that. Soon you will be able to have your blood tested and see if you have an IgG titer. And I would think that would be reassuring. But because we don't know, I would still wear the same PPE that is recommended for everybody.
All right, Dara, you're still going to have to wear an N95 when you're intubating, still going to have to wear those surgical masks when you're taking care of patients. Dave, let's talk about some of the other questions that have come across that I think you're going to have the answers to. Let's talk a little bit about medications, because we are hearing a lot about chloroquine, hydroxychloroquine, azithromycin. I know we talked about this a little bit last week, but things change, especially when you have, you know, somebody getting up there and saying that we should be doing this. What are the role for these medications right now? And you know, the intensive care level patients, we can talk a little bit about that with our intensive care colleagues. Let's talk about the regular patients, the patient who's coming in, who you're going to send home. Is there any role for these medications, or even in the moderate illness, is there a role for these medications right now?
Well, Swami, maybe we should ask our guests if they got prescribed hydroxychloroquine or they took azithromycin.
No.
Yes.
Okay. Well, I'm glad we have a consensus anyhow.
I had a friend of mine who, yeah, go ahead. It's the first time I've admitted it out loud in public.
Oh, it's okay. So
admission is the first step, Dara.
Yeah.
I know. I can't. This is EMRAP. There are no lies here.
Well, what did you take though? It's perfectly understandable. But what did
I took hydroxychloroquine. A doctor was taking care of me, actually, and he felt that it was early on, but he was like, you know, I was having symptoms he was concerned about, and he felt like it was a safe medication for me. He wrote me a prescription, and I took it for 5 days. He followed a protocol, experimental protocol that is being used in a study. He just wrote me a prescription. And this is before, I want to be very clear, this is way before there was a public tweet and a medication shortage on this. I was diagnosed early enough that it was more just like, hey, let's see what's going to happen. And I think it's a good medication for you particularly. But this was not once this became a free-for-all, there would not be a choice I would have made.
So we just want to know, like, you have an N of 1, and after you started taking it, did you notice a change in the trajectory of your illness? And then the second question is, are you going to write yourself up as a preprint in one of these journals?
So he's trying to, actually. He has a bunch of patients that he was caring for that actually took it, and he thinks that it really did help. I don't know. I think I was going to have hopefully a mild course regardless, but I do know that I'm happy to say that I had no side effects and took it according to a physician's orders and recovered quickly with very, very few scary days. And so for that, I'm thankful.
Okay. And,
can I jump in and ask a question, Dave? I'm back up.
Okay.
I think.
So, we can hear you.
Let's talk about the Singapore experience. So a lot of people are freaking out that you have to wear PPE, N95 masks all the time. You sent me some really interesting information from Singapore. Can you sort of explain that maybe this is not as aerosolized as what they basically did is took the virus and aerosolized it and said, look, it stays up there for a long time, but that's not the real world experience. Can you explain?
Yeah, well, I think our colleagues, I mean, we're all scared, and we're kind of wondering if a regular surgical mask is sufficient during the routine care, not high-risk procedures like intubation. Is a regular mask and contact precautions sufficient? And of course, that is the recommendation of the Centers for Disease Control and the World Health Organization, but there is actually sort of this, kind of a feeling about, is there a deep state conspiracy? Because in reality, we have a shortage of these supplies. So maybe these organizations are just recommending this, and they don't know for certain that they're optimally protective. So, I think if anyone who says they know the answer for sure, you should look at them suspect. But I think here's what we know. Mel, you referred to a study a little over a week ago in the New England Journal where they nebulized SARS-CoV-2, and then they were able to demonstrate it on tissue cultures surviving for a few hours in the air, and then for longer, a day or longer, on surfaces, less on metals, or less on cardboard and more on metals, longer on metals. So the concern was that if it can be aerosolized, and again, this wasn't aerosolized naturally in someone who was coughing, this was like a machine that put it into the air. Does that simulate what we're walking around in these emergency departments like we're described in New York City and New Jersey? And should we instead be wearing more protective PPE like N95 masks all the time? Or certainly when we're talking with patients with respiratory illness and we don't know yet if they're COVID-19 infected. Here's what else we know. In that very same study, they looked at the survival of the related serious coronaviruses. So the original SARS virus and the MERS virus, and they found that they behaved and survived very similarly to the COVID-19 virus. And we know that for those epidemics, let's take the original SARS epidemic, which was just as transmissible and even more dangerous, that careful droplet and contact precautions ended that transmission. So I would find that part of the experiment reassuring. And then I think, Mel, you referred to another study that was published about a week after the one we just talked about in JAMA. And in Singapore, they sampled the room, the air and the environmental services that housed 3 symptomatic patients with COVID-19. And they, instead of using tissue culture, used PCR, which is actually even more sensitive to detect any virus, virus both alive and remnants of virus that would not infect you. And with that very careful technique, when they sampled the air of these 3 symptomatic patients, they could not detect SARS-CoV-2. Now, they did find it on environmental surfaces, and we've talked about that before, but that speaks to careful hand washing, right, and contact precautions. They didn't find it in the air, which would suggest that routine N95 masks should not be needed. And they also didn't find it on the caregiver's PPE. So it doesn't seem like something that is in the miasma that you can breathe around your cervical mask, or that is going to stick on you and on your clothes and gowns and other PPE that easily. So I think the sum of all this would support the recommendations that are out there, but I'm sure we'll still be learning more.
Thanks, Dave.
All
I'm
right.
going to move us on to the sort of the critical care part of this, and then we'll get back to some of the questions that we're getting from the audience about other therapies. And thanks, Swami, for jumping in and taking over so seamlessly. What a pro, ladies and gentlemen. What a pro. So I've got Scott Weingart and Evie Marcolini, who are critical care peeps. And since we're really getting this ramp up in New York, of having to intubate a lot of people and care for a lot of sick people, I thought I'd bring them in to ask them some very specific questions. But first of all, I'll go to Swami and say, have you been using non-invasive ventilation in these patients? And then we're going to have Scott tell you why you're stupid or not. And do you have any concerns about whether you're taking that virus and firing it into the air.
That's the theoretical issue with this is, even with a good non-invasive mask, are we just aerosolizing more particles, increasing the risk of getting exposed to this? Scott can definitely comment a lot better on this than I can. We are using it, especially for pre-oxygenation before intubation in the patients who are really sick. We are doing it with a dual system that has separate ports or separate tubing for both inhalation and exhalation, making sure we have a good mask seal. And we're using viral filters as suggested by Scott. And that's why I'm saying that he can definitely give a lot more comment on this. But viral filters, making sure that we are not spewing those particles into the room. But it's really hard sometimes to oxygenate these patients. They're often coming in with sats in the 60s, low 70s, and that's not a great place to start your intubation process, obviously.
So, Scott, can you address that? First of all, I was told when I was a young boy that BiPAP, non-invasive ventilation, is good for things like CHF, but for pure pneumonia, it's not very good. Is that true? Is this changed? What do you think?
It's changed. We could definitely take like full-on acute lung injury in ARDS patients and manage them with non-invasive, given how severe their disease is. The obviously really severe ones would always get intubated. But no, there are definitely pneumonias and shunt physiology, respiratory failures you can manage with non-invasive.
Are you concerned about us getting lots of virus particles in the air using this stuff?
We're in a real point of risk-benefit decision-making. It was put best by one of my colleagues on the EMCRIT team, Rory Spiegel. And if we figure that this disease course is somewhere between 10, 12 days, and you could take patients and keep them off the vent for 4 or 5 of them, even if they wind up getting intubated, you've now reduced a vent stay of 12 days to 8. That has huge ramifications for the other patients. So that's still a win, even if that patient got intubated, because you only needed the vent for a smaller period of time. The problem becomes, are we putting our staff at more risk? And the answer is maybe. There are definitely safer ways to do it. If we had negative pressure rooms in every room in the hospital, I'd say put every single one of these COVID patients on non-invasive, whether it be high flow nasal cannula or the classic, mask-based machine therapies, and just do it, because I think with negative pressure rooms, the risks are worth it. Without, it becomes a very difficult decision. The risk is, and the studies that Dave mentioned, I'm not sure if any of those patients were actually on non-invasive. We know intubation is an aerosolizing procedure. We think that the BiPAP or CPAP type systems are, and the data is kind of varied on the high flow, but my guess would be the high flow, meaning you have these patients on 60 liters of oxygen through their nose, probably aerosolizing. Now, if the staff is going in there with the same PPE that they would have been during an intubation, maybe that risk trade-off is worth it if we keep patients off the ventilator.
When you cough or when you sneeze, you are firing this out at about 400 liters per minute, is my understanding. Yep. So 60 is less than 400, but it's still not 2 liters a minute. So we don't know, and I don't know if we'll ever know. So let's then ask you to take us through intubation now. I know you could speak for 6 hours on this, so be nice. Yeah. But very specifically, you and Swami did a nice little review of this. Some of the tricks that you would do in a patient where they're probably infected that might reduce the physician's exposure, because the evidence that we have from prior epidemics is that this appears to be a very high risk time for you.
This is it.
Take us through that, and then Eva, I'm going to talk about LMA versus intubation. So
sure. All right. So we have to talk about PPE first, and so you have to go with what your hospital will provide. But I think in an ideal world, you're wearing an N95 mask. You're wearing something over that mask to prevent any droplet or spray contamination onto your N95. You want to have something that covers your entire face. Now, we have those disposable welder shields. That's workable. You need something that's going to cover your neck. I think this is the most often ignored area, is we're wearing a disposable gown. We might even have beautiful face shields, and then this area is just open. And then it's easy for fomite contamination, or I don't know, Dave, you can tell me, are we a fomite? Is that still the same word when you touch your neck and then touch your face? Is that still fomite contamination?
Yeah, I guess so. I guess
Yeah. All
you're a
right. So we are
Fomite
now
too.
the fomites.
Yeah.
Always love that word. So that's an often ignored area. Ideally, you'd have something that covers your legs as well. Now, I've seen this is often not had in any hospital, to have some kind of leg covering. And then shoes. Oh my God, no one is wearing Ebola booties for this. And so in a really perfect situation, you'd have shoes that could be easily sprayed down with bleach or isopropyl alcohol, and someone would spray you during your doffing. But in an ideal world, full face, neck, hair, something disposable over at least your chest, if not your full body, and then some plan for your shoes, whether it be decontamination afterwards, or you just vow you're never going to touch your shoes at any point during your shift, but the shoes are a big problem. So now you're going to go in. Now, where are you going to go in? Ideally, you save your negative pressure room for the intubations. I think I agree with Dave that the risk is pretty low during routine care for these patients, whether they have a tube in their throat with a viral filter on it. Now they're pretty much safe, or before that point, so long as they're not getting aerosolized stuff. So I really feel we should save our negative pressure rooms for the dangerous procedures like intubation. And so we save our room. We only have one in my ED ICU. We just have one. So we save that. We keep that empty, and we move the patient there for the intubation. Then we get them the hell out of there after we tube. So you have a donning buddy before you go in to make sure that everything is covered. You look good. You haven't forgotten some crucial piece. Like, I never know when I'm wearing my eye protection or not, because it feels the same to me over all the other crap I'm wearing. So having someone look and say your eyes are totally exposed is a really good thing. Most experienced person should be doing the intubation. Now, this is where humility comes in. If you're in a community center, then the attending is the most experienced person. But if you're in an academic center, and it's been 10 years since you've done anything except watch an intubation, and your fourth-year resident is the most skilled person there, then it might be in consideration to let the resident do the intubation. In some places, it might be anesthesia doing that intubation. You know, that's anathema in the United States for emergency medicine in general, but this is not the time to extol, you know, how wonderful we are. You have to take a good, hard look at yourself and the people around you and say, am I the best person suited for this purpose? And so that person should go in there. I have a strong feeling that everything you need should be prepared before you get in the room. We have made intubation packs, disposable, bags with everything I need. That's not the laryngoscope. We use a video laryngoscope itself and the medication. So everything is in that pack, such that when I get in there, I know I have every item I need. And so now I'm going to go in, I'm going to take in my meds, my video laryngoscope, and my bag. And I only allow 2 people in the room during our intubations. If that's a second resident, that's okay. If it's not, then it's going to be a nurse. But I don't allow a resident and a nurse. This is not the time to learn from, this intubation. It's just 2 people in the room in my experience. I don't even bring in my RT. Some places do. I leave them outside with the ventilator, and I'll call for them when I need them. And then a trick I picked up from my buddy Chris Hicks is I make a phone call to my buddy outside before I go in the room, and I put it on speakerphone, and I put that in my pocket. And now I could have direct communication with the outside without having to bang on the glass like we're some horrible zooed animal. So now I'm going in. The first thing I do is I put a non-invasive mask on the patient with a viral filter on them. Now, if they cough, if they sneeze, what have you, I am protected. They're not getting oxygen yet. I'm going to do that next, but I'm protecting my team. If they're not going to tolerate that, I'll push ketamine at that moment. DSI right away. I'm not going to have this situation where I have to fight with a patient in my full PPE. So I'm just going to dissociate them immediately if they can't tolerate that mask on their face. And then I'm going to put a setup that I'm not even going to try to relay online. You could go to EMCRIT.org and see it, but it allows me to pre-oxygenate these patients with CPAP in a super safe manner with a BVM and an end-tidal CO2 port in a way that is, I think, easy to set up before you go in the room, and we'll get the job done, not just with near 100% FiO2, but with a good amount of CPAP if you need it in a way that is safe. The only thing going into the room is whatever tiny leak may be around that mask. And now I'm going to pre-oxygenate the patient while I put all the stuff on a table ready to go for me. It's going to hopefully be a first pass intubation with a video laryngoscope. Why video? Well, you could argue till the cows come home about the advantages of video versus direct before COVID. But with COVID, direct is this and video is this. And so that's an easy sell for me. I would like to be as far away as possible. We know the zone of safety pretty clearly is outside of 6 feet away from that patient's mouth. It may even be 3 feet, but 6 feet is a very nice place to be. If I could take 3 extra feet by having my arm extended instead of having to stick my face in the patient's mouth seems like a win. Now, before I take off that mask, I'm going to paralyze that patient, whether I did DSI, where I gave the ketamine and then pre-oxygenated, or RSI. I'm going to push my ketamine and my rock at the same time. I'm going to wait till that patient is fully paralyzed, as in no chance of coughing, before I take off that non-invasive mask and then go for first pass success. And I'm hoping I could get that as soon as I have a cuffed ET through the cords with the cuff inflated and a viral filter on top of that. Now, my setup for pre-oxygenation is the same one I could stick right on top of that ET tube. Once I have that cuffed ET and a viral filter on top, now I can wave in the RT to bring in the vent. And meanwhile, I'll bag through that same setup. Then once the patient's all in the vent and I've put in an OG tube and I've done any procedures that need to be done, now's the moment. Central line, left IJ. Why? Save the right IJ for possible ECMO use. Arterial line is what we like to have at our hospital. Some places aren't doing it, but if you're going to do it, now's the time. And when I'm totally done, now I'm going to go outside to my doffing buddy, and they are going to take me through a checklist of doffing step by step with hand hygiene between each step, because this is probably as dangerous as the intubation itself. Mel, Swami, what did I miss?
Oh my God, I'm exhausted. Actually, Dr.
I'm
Marcolini
exhausted too.
wants to make a comment. Go.
Scott, I completely agree with everything you said. And I have watched the video that you put online. Everybody should watch that, about using the nasal cannula and the CPAP setup to make this scenario safe for the people who are intubating and the people in the room. And I'm probably the only person on this screen right now who works at a rural suburban setting. I'm at Dartmouth, and I've got to say, our hospital has done a great job of communicating, of organizing, of preparing, and of letting us know what's going to come down the pike. Communication is the biggest thing. And I have been on shifts where the screening is one thing at 8 in the morning, and it's a completely different thing at 4 in the afternoon. So all of this about intubating, how we intubate, which room we use, the most experienced intubator, et cetera, that changes with regard to resources. This is all about resource allocation, because we've talked about intubation for a long time, and all these things have been in the literature and on your podcast for a long time, but it changes now when you don't have a negative pressure room for everybody, when you don't have the PPE for everybody. And I think there's probably a lot of folks on listening right now that are working in smaller community centers that just don't have the PPE and don't have the negative pressure rooms, and maybe not even the training on how to set up that ventilator themselves. So they're going to have to adapt and bring the respiratory therapist in the room with them. We talked a lot about our intubation protocol, and there's a small group of us. 4 of us are critical care emergency medicine in our group, and we put together the protocols of how we're going to intubate patients in the emergency department. And 2 very important factors of that. Number 1 was, who should do the intubation, and should it be the most experienced? Are we going to take the residents out of this? We want to continue resident education. Resident education now is hurting, and we're trying to adapt and use online strategies. Do we really want to take that intubation away from them? Some of the considerations were exactly what you said: protecting the residents. And this is not the time to learn. If you happen to be the most experienced person and you're the resident, then yeah, you should be the one intubating. It's about patient safety, and it's about workforce safety. And the other thing is, we have an anesthesia team in our hospital that has been designated the go-to team for critically ill patients who are getting intubated. And I know that there's places and people who are listening to this right now saying, wait a minute, I'm the emergency physician. I can intubate this patient. I don't need an anesthesiologist. And we've been fighting this fight for a long time, but I have to reinforce what you said. This is not the time to be territorial or to be turf. This is the time to do the best for the patient and to protect ourselves, because we're the front lines. We can't take ourselves out of the game by not being prepared. So in our shop, We are the frontline intubators, but we're very cognizant of our resources as far as people go and numbers of patients. And we will call our anesthesia team when appropriate. And it takes judgment and it takes humility.
And I got to sort of note as well that CRNAs are being called down when things are overwhelming. And again, I agree with you. Put your ego on hold. This is extraordinarily timed. And happy birthday, apparently.
Who told you that?
The internet knows everything. Swami, you wanted to say a few words?
Is it her birthday, or is she just washing her hands?
I got a follow-up question for both of you guys, Evie and for Scott. Ideally, we would keep these patients in negative pressure rooms forever, but most places don't have a lot of these. I've talked to a lot of people who work in rural settings where they have one or none negative pressure room. I happen to have 4 or 5 in my place, which is a lot. After I intubate the patient, can I move them out of that negative pressure room? Because I'm going to have another one coming right behind them that's going to need that room again.
I think so. I think they're now probably the safest COVID-19 patient you're ever going to treat. With the proviso, and I had 2 high-level exposures through this, is intentional or unintentional circuit disconnects are really problematic, because now you have, depending on where the disconnect is, you potentially have that filter that's been holding all the COVID spraying around the room at insanely high flow rates. So as long as people are really cognizant to make their connections tight, and if there's an intentional circuit break, doing it in a safe manner, which involves clamping the tube and disconnecting the patient from the ventilator temporarily. With those provisos, I think that's a pretty safe patient. I certainly would not be using the negative pressure room for the intubated patients. I would be saving the negative pressure rooms for the intubation itself and for the ones that we could stave off intubation with some form of non-invasive positive pressure.
Evie, did you want to say something specifically about LMA versus standard intubation?
So LMA or any supraglottic airways are a concern. In EMS, we are asking our EMS providers to take care of these patients and on the front lines, and they have far fewer resources than we have. So one of the questions becomes, are they going to use an LMA? Are they going to use a King airway? Are they going to use any kind of supraglottic airway? There's risks and benefits to both of these. For the LMA or the iGel, which is something that in our region, some of the services are carrying, or the King airway, you have to think about how easy is it to put that in versus intubating. And most of our EMS providers don't have video laryngoscopy. So to ask them to do direct laryngoscopy in the EMS setting, in the back of the ambulance or on the kitchen floor or something like that, I think it's a consideration that it's much easier and much safer for them to place a supraglottic airway. Scott.
Yeah, I totally agree with you. But I want to put some pointers out there that I think you'll agree with. I mean, we are kind of the same mind in most situations. First off is, I don't think people who are not familiar with the supraglottic airways like the LMAs understand, as well as people like you and I who use it every day, that they cannot just be put in and left. They need to be held with inward pressure, whether that be by your securing or by you holding your hand there. Otherwise, there's no seal. These devices are made to have slight inward tension. So if this is, something they're not familiar with and they're just, putting it in, and the iGel is beautiful. You can just blindly stick it in for the most part, but it requires you to keep inward pressure, both for effectiveness, but also for protection for them. I think it still needs a viral filter. And I think, and this is the key, and unfortunately in exactly the circumstances you describe as, this might be the move because it's rural, they might not have much equipment, is exactly the wrong situation unless they have end-tidal CO2 monitoring, because that tells you 2 things. If the service is placing LMAs and they have end-tidal CO2, if they're getting a nice waveform, it tells you, first of all, the patient is being ventilated, but second of all, that there is a seal, and therefore they're not putting themselves at risk. And without that, I'm very reluctant. But if they could put this device in and either tape it in or hold it in, and they see good end-tidal, it means the seal is intact, they're safe, the patient's getting ventilated. And the one thing I'd add, and there's no data for this at all, but other people are doing it, is putting a tarp. I shouldn't even say a tarp. That implies like this heavy thing. Putting some clear piece of plastic over the patient's face once that LMA is in and just bagging underneath it, I think is one additional barrier to aerosolization.
I completely agree. Yeah, the plastic sheet over the top is kind of a new thing that I saw recently, and I like that idea a lot. And as far as the supraglottic airways, you have to know the details of those. If you're using the King, there's a little device on the side that you can attach to suction with, and if that's not covered, that we're talking about is possibly being an aerosolization source. You have to really know the equipment and what you're using. And I've always been intrigued by EMS bringing the patients in with whatever it is. It used to be EOAs, now it's Kings, it's iGels, it's LMAs. And what do we do when we get those patients? How are we treating those patients? Because we don't really use those in the emergency department. We go right to intubation. We have to know how those work as well. And when we switch those out, if we're going to do that, we need to be safe about that too. It's there is no data on LMA or supraglottic airways versus endotracheal intubation out there for COVID, full stop. We have to be mostly intuitive.
I got a logistics question for both of you guys on this. We've talked about the tube, end-tidal CO2, the suction, the viral filter. Where's the viral filter going exactly? So I've got the tube. What comes next? What comes next? What comes next? Where does that viral filter fit in?
I'll lay it out, and then Evie can tell me I'm totally wrong. And so for us, it's ET tube to inline suction. This is where the 2 circuit breaks that I got exposed to were, because the inline suction was not in our intubation packs, and therefore later on, when the patient started having secretions, we had to do a dangerous circuit break at the exact point you don't, which is between the ET tube and the viral filter. So now we put that in our intubation pack. So ET tube, inline suction, viral filter. Past that, it just doesn't matter. It could be your HME and then your end-tidal, then your HME, depending on whether, humidity is a problem for end-tidal setup. Now, I will say one thing. There's a chance that putting the HME directly after the inline suction will save the viral filters. This wasn't an issue for us when we had plenty of viral filters. As the stock in the country is dwindling, having yet another moisture barrier, because that's what kills these viral filters, is they get sodden, they get contaminated with secretions, because they're blocking out all the humidity from the patient, and if they're coughing up crap. So perhaps what the ideal would be if you're in a low viral filter situation is ET tube, inline suction, HME, that stands for heat moisture exchanger. It's what the passive humidification on most ED vents is done with, because we don't have the beautiful systems that the ICU folks do downstairs. And then the viral filter, and then your end-tidal CO2 in your circuit. What do you think?
I agree. I agree with you. And I have to put this out there again, is in the pre-hospital world, I just hope that our folks do have these filters. I don't really know if everybody does. And we may be running out of them soon.
So can you now talk about how to ventilate the patient? Let's say we did everything right. We got the tube in. Scott, what are you doing specifically with these patients? Is it just an ARDSNet-like protocol? Is there something special?
So this is so difficult to answer, because we have no hard data. Everything is anecdotal reports, and the anecdotal reports kind of contradict each other in many situations. I think the safe path to go is some form of low tidal volume situation. I'm varied opinions on whether you should just start them at the 6 mLs per kg of predicted body weight, or 8 is okay, because these patients are remarkably compliant in their lungs. They will not have high plateau pressures, dangerous vent pressures, like many of the later stage ARDSNet patients do. So maybe 8 cc's is okay, and it might decrease your need for high respiratory rates. But somewhere in that range, I think everyone would agree, 6 to 8. Enough PEEP to recruit them. And this is what we talk about all the time in the ICU. This is our coffee conversations. But these patients seemingly de-recruit fairly easily, and CPAP or PEEP fixes their problems. And so you need enough to get them satting greater than 90%. And then if you use the ARDSNet scale, it'll tell you what FiO2 you could use for whatever PEEP you need. And therefore, you won't have to think about that. The thing that is my belief, so this is not evidence, but this is my belief, is that these patients being kept spontaneously breathing is a good thing, and it's what keeps them recruited. And it's why I think modes like CPAP purely, even if they have an ET tube in, or a mode we call airway pressure release ventilation, APRV, which is what shock trauma beat into us, a mode where the patient's fully awake, fully initiating their own breath, spontaneously breathing throughout at very high CPAP levels makes a ton of sense. And anecdotally, my friends and myself have had good success with this strategy. Now, your vents in the ED may or may not have this, and you may not have ever touched it, but the idea of trying to keep the patient spontaneously breathing on a good amount of PEEP or CPAP is virtually the same concept.
Evie, what about proning? We hear a lot about this. Please explain it to the ignorant like me. You just flip them on their belly and then you recruit some more stuff and then you flip them back. How do you do this?
So with COVID patients, the whole focus is hypoxemia and oxygenation. And in some patients, they're going to have a lot of recruitment opportunities. So they're going to have lung fields that are needing recruitment. And that's when Scott's talking about using PEEP. And I as well am a fan of APRV. Now, most of the literature out there is going to tell you to use ARDSNet. I don't think that's wrong. Low tidal volume, and using 6 milliliters per kilo tidal volume, keeping your plateau pressure less than 30, maybe your respiratory rate goes up to 35. If your PaO2 to FiO2 ratio is less than 150 or less than 100, then you have to move to other maneuvers. You have to move to next things. Again, like Scott says, there's not a lot of literature. There's not a lot of data out there to tell us exactly what to do. So we're going on data and literature that we've seen in pneumonia and that we've seen in other settings. First of all, you're going to try to increase your PEEP. And this is where APRV might be better, because APRV is a recruitment maneuver type setting, and it's going to keep those alveoli blown up. But APRV versus ARDSNet aside, you want to focus on PEEP to increase the oxygenation. And I have to go back to say, before you even intubate the patient, if you're using high flow nasal cannula versus CPAP, the goal oxygenation is 92 to 96%. You don't want to be above 96%. You don't need to be. You're increasing the risk to the patient as well as to yourself, whichever maneuver you're using. And so now you've got increasing PEEP. The next thing is you can try a recruitment maneuver. Recruitment maneuver means giving the patient 30 cc's of 30 centimeters of water pressure for 20 to 30 seconds and seeing if that helps. There's no great data out there that it does help, but you can try it. The next thing to do is to think about deep sedation. Maybe you're going to paralyze the patient, but you're going to try to take over their breathing. And the next move that you might think about making is proning. Proning simply means taking the patient and putting them prone on their belly instead of supine. All of our patients in the hospital are used to being supine. That's the way we see them. That's the way we like them. But if you look at the lungs in most of these COVID patients, all the dependent areas have the vasoconstriction, the consolidation, the fluid. If you flip them over, what you're doing is allowing those dependent areas to recruit, to get their alveoli open, and to bring more flow, blood flow to that area as well. And there's varying opinions as to how long you should keep somebody prone at a time, flipping back and forth. I'll tell you the biggest problem with this is if you're in a system where you've never proned anybody. I mean, Scott and I trained in a place where we proned people all the time. And so we know how it looks, we know what it looks like, and we know that you need about 9 people around the bed to actually do it safely, because you definitely don't want to lose the tube or any connections to anything. If you're not really experienced as a team in doing this, it's probably going to be too risky. But if you have sim centers, you should practice this. All of this stuff, from the intubation to the proning to everything else that we do, should be simulated, and we should practice it. But proning has been shown to help in some cases, but it's not without its risks.
I'm going to go backwards a little bit here, and because I'm looking at the chat room, People are asking about ketamine versus etomidate for intubating these patients. Scott, you want to take that one?
Sure. I mean, this is an endless debate, and then we'll next get into sucks versus rock. It doesn't matter. Etomidate's fine if that's what you're comfortable with. The only reason I carry ketamine into the room is because of the exact reason I mentioned, which is if the patient will not allow me to get everything ready, or they're coughing everywhere and they won't tolerate the mask, ketamine allows me to do delayed sequence intubation, allows me to give a dissociating dose of the ketamine, chill them out, then I could do everything I need to. I can't have that with etomidate. So now I'm going into this blind situation, and it's now either push the meds without pre-oxygenation, which in these patients is a really dismal state, or expose myself to a flailing around coughing patient who's not tolerating pre-ox. So that's why I prefer ketamine in this case. But if you're more comfortable with etomidate, if you've never used ketamine, then it's not the first time to try it on your COVID intubations.
And what about sucks versus rock? Evie, tell us about that.
Well, I'm a sucks fan, and oh, sorry, I got that wrong. Sorry, I'm a rock fan.
Oh, thank God! You hurt my heart for a second. Now Billy Mallon's the only one left who's a sucks fan in the universe.
Yeah. I'm a rock fan for many reasons. First of all, I think that at the right dosing, you're going to be able to get as quick onset of paralysis as you need with rocuronium. Number two, this is not the time to be messing around with trying to paralyze your patient. If you miss on the first try with succinylcholine, you have to re-paralyze the patient. And re-paralyzing with succinylcholine, you run the risk of bradycardia. When we go in to intubate these patients, when we make a plan outside the room, we're making a plan to be ready for cardiac arrest and what we're going to do. So we need to recognize that this patient, just because they have COVID, is still a critically ill patient and can really have all the same complications that we've talked about with all of our critically ill patients. If I'm needing to make a second attempt, I want that patient to have been paralyzed. Most of these patients are going to be pulmonary patients. We talk about neuro patients and how you lose the exam if you use a longer acting agent. But in this case, most of these patients are pulmonary, and so I don't care as much about that. So I'm a fan of the long acting agents.
Evie, Scott, I have a question on nasal
Can I
oxygen.
add to that for a sec, Swami?
Yeah, please.
Totally agree with everything that was just said. I will say, some of my friends talk about, I intubated and all of a sudden, they were doing pretty okay on 6 liters nasal cannula, and then their, PEEP and FiO2 requirements went through the roof after I intubated. And I believe a large part of that is you've taken these patients from negative pressure ventilation to positive pressure without adequate PEEP. And you have taken them from sitting up in bed doing this beautiful negative pressure recruitment work to lying them flat for the 45 minutes they're on the rock paralysis. So I think if you use rock, and I do, you need to put a reasonable PEEP up there right up front and keep the patient sitting bolt upright in bed for as much as possible. If you have to lie them down to put the central line in, fine, but do not leave these patients supine for the 45 minutes after rock on 3 of PEEP. They will 100% de-recruit.
One thing, guys, that we heard from Jenny and Dara, and we're seeing in a lot of other hospitals, is the lack of ventilators. And so a week and a half ago, when I was seeing a patient with COVID who was having some respiratory distress, we were getting them to intubation pretty quickly. Now, my last shift I went in, I had a guy who came in, he was like 85%, tachypnic to 35. And I know how few vents are in the hospital. So I stuck him on some nasal cannula and he did okay. He actually did great. Over the 8 hours after I saw him, he was doing great, good saturation. Are we beginning to switch and say that maybe we can bridge a lot of these patients and never get to the vent? And how do we make the decision of whether we should do that tube right away? I mean, we know there are some patients where clearly you look at them and you're like, there's no choice here. I got to tube this guy. But when should we pull the trigger? Are you trying these other interventions for a little while and then saying it's just not happening? Or are you giving them a little bit longer on it, knowing what your limitations are as far as providing continuous mechanical ventilation?
I want to take a stab at that and talk a little bit about the high flow nasal cannula, because I can remember the first patient that I intubated a few weeks ago that we were concerned about COVID, and there was a lot of fear of the high flow nasal cannula in the room. And we have no hard data that aerosolizes any more than, it's much less than a cough, like Mel had said earlier, 400 liters per minute is much more than 40 to 60 liters per minute. And we actually did use high flow nasal cannula on that patient, and it decreased her coughing. So we actually were decreasing what's going on. So high flow nasal cannula gives you some PEEP. It's less maintenance, less attention. You don't need the respiratory therapist in there as much, in and out, taking off your PPE back and forth. When you put that on, you can watch to see how the patient goes, and then kind of let it go. And you can watch from outside the room if you need to. The data has shown that it's better than non-invasive positive pressure ventilation like CPAP for pneumonia back when we studied that. And actually, in the SARS outbreak, healthcare workers didn't have an increase in their risk of disease when they used high flow nasal cannula. So I think there's a fear out there that's not based in data. And if we do use high flow nasal cannula, we do know that we're going to put off the need for the patient to be intubated, especially if we're worried about number of ventilators. And if we can take up 4 or 5 days of that patient's illness by using high flow, let's do it. And then if they need to go on the ventilator, then they can.
Let's go a little bit more extreme now. It's we're completely overrun. There is not enough ventilators. I asked Scott this before and he said it's stupid, but I'm going to ask it again. What about this idea of putting 2 or 4 patients on a ventilator? I understand that you can't tweak the ventilator to the settings that you want because that's difficult. You're going to try and get 4 people around the same size, but this is an extreme situation. Otherwise, they're all going to die. Is there any tricks to doing this, or is Scott, this just stupid?
I'm not going to say it's stupid, and I hope I didn't say it was stupid the first time, though. You know, I'm kind of histrionic. I might have, but it seems to me so far down the last resort hole that I'd rather we don't get to this. And there's so many things that could come before this. There's stealing CPAP machines from sleep apnea patients in the community. There's reutilizing and jury rigging machines that were meant for non-invasive, for invasive ventilation, if you could do it safely. There's taking the backup ventilators from all the chronic vent patients in the neighborhood if they're willing to part with, not their main ventilator, but most of them have 2 ventilators around. There seems to be so many stopgap measures that would stop this from needing to be a necessity. This is not good. And it's not just good because the patients can't spontaneously breathe anymore. They need to be so deeply sedated, they're not taking a single breath. I really am troubled by our ability to adjust things like PEEP well, things like for different compliance, even if the patients look the same size. I am just not convinced that this should happen without exhausting all the other better options out there.
Okay, so it's stupid, but it's the last type of stupid. All right. So I got an ethical question here that a number of people have been asking. When the docs have run out of their protection equipment, do you think that it's reasonable to ask them to go in and intubate patients?
I think it's
Evie, I'm going to answer that.
Yeah, I'm sorry.
Oh, no, I don't. I think that we need to lobby for and advocate for PPE, appropriate PPE for all of our healthcare providers, physicians, nurses, pre-hospital folks, and everybody. We need to be properly protected. And I just wanted to add one thought to that conversation about the multiple patients prevent is one of the things we don't quite know yet is how long are these folks needing to stay on the ventilator? What's the natural progression of this disease? And to bring ethics into this, there's a large conversation around resource allocation in the world of ethics of how long do the patients stay on? We do know that in Italy, patients were being taken off of ventilators to give those to other patients. And there's some conversation around saying that there should be a certain number of days that patient should be on a ventilator. Now, working in the ICU, I know that we can take a look at a patient and see how long they've been on a ventilator and give a trajectory, a guess, and say, this patient is going to come off the ventilator or they're not going to come off the ventilator. We're pretty good at doing that. We're not perfect, but we're pretty good the farther out we go. Once you get into 2 weeks, 3 weeks, at least 2 weeks, you know whether or not that patient's going to get off the vent. Should we take these patients that far? And that becomes an ethical question of resource allocation. And that hasn't been answered yet, but it certainly is being talked about, and something that most, if not all, hospitals are thinking about.
Maybe one of you can answer this. Sarah Krieger, who couldn't be with us tonight, sent me a paper about having family members bag people. And I see it come up in the chat here as well, that in extreme situations, people have been bagged by family members in a rotation fashion for 18 days. Do you have any thoughts on that?
I'd rather that happen than the vent splitting. You know, I have a whole bunch of people have contacted me through various think tanks to just create a easy to 3D print device that would squeeze the bag so that the family member, if they fall asleep, have not killed their loved one. That seems very reasonable. I think you could work up a very usable ventilator situation simply with a BVM, a PEEP valve, and some form of oxygen flow, very similar to the pre-ox setup that Swami mentioned. I think there are solutions out there that can happen within the time course we need them to, that will prevent having to split ventilators.
Scott, how useful are the anesthesia machines for providing ventilations here as opposed to our typical ventilators that we have?
I can only speak for the places that I've had familiarity with, which all have very up-to-date anesthesia machines, and they're just as good as an ICU ventilator. The ones my wife uses are basically equivalent to our ICU ventilators. Now, if you haven't updated your ORs since 1970, you might have a horrible ventilator. So it's really going to be a center-dependent situation.
Dara has a question as we sort of wind this up. And of course, we're going to be doing more of these, and we'll get more experts back, as we just can't cover everything. But Dara, do you want to ask that really important question about you going back to work, and what does that mean, and your family? Hit us with
So this actually is coming from my husband, who I think asks questions that regular people ask me that I don't always have answers to. So his question is, so we know the protocol from the CDC for going back to work for people that have been infected is basically no earlier than 7 days of onset of symptoms and 3 days from last fever with a improving course of illness is what they say. You can go back with a mask. He's like, okay, that's great, but can you walk around our house without a mask? Right? What is our risk of infecting others in our family from either onset of symptoms? I mean, most of us aren't actually even be able to get diagnosed. So how do we reintegrate in our family without worrying about, am I still infectious to him? They're letting us go back to work. We know that, with a mask on and take care of patients. Can my kids move back home? I moved my kids out so that I wouldn't infect them because I had a son that had liver transplant, right? I was successful in heading off the infection. So he left. Can he come back? Right. So how infectious am I, and what's the time course we're recommending to clinicians and healthcare providers who get infected to reintegrate into their families?
Right. Scott, take that.
You got to be kidding, brother. It's all you.
Answering the unanswerables.
No. I mean, there's pretty good data. You know, we've had a lot of people infected, and they've been followed for how long you can measure the virus in their throat, right, and their respiratory secretions. So I think that there's a pretty solid basis for that CDC recommendation. So I'm okay with that. We also have a lot of experience now all over the world, but even in the United States now, about home quarantine situations, and where we see people at home during that infectious period practicing sort of the usual hand washing and contact and droplet precautions, just like, you know, we talk about at work. We don't see secondary infections. So I think the home situation, I mean, it's a lot of stress on everybody, and certainly no one wants to take any risk with the people they love the most, who are closest with them, and children. But I think, you know, the recommendations for home quarantine, and when you go back to work, and when you can come out of that quarantine situation, I feel that those are pretty safe.
So when can I no longer be 6 feet from my husband and let my kids back in the house? What day from symptom onset, what would you say?
Well, I would say the same recommendations that allow you to go back to work, would allow you to be safe at home. And you can be near your husband. You should be wearing a mask if you're symptomatic.
Okay, so
right?
asymptomatic, I shouldn't worry about being infectious.
Right.
Okay. Scott, do you agree with that? Oh, sorry.
It's good news.
I'm a resuscitation doctor. I have no friggin' idea. I'm not that smart.
Dave, I got a quick question. You know, we're obviously trying to send a bunch of patients home. I think you've just finished up a huge appendicitis study. Are you allowed to talk about that yet? Is this another group of people we can send out of the emergency department?
I can talk about it. So, you know, we were involved in actually the first NIH sponsored trial, first trial in the United States, looking at non-operative treatment of appendicitis, where our innovation was that if they were randomized to antibiotics and they were stable, like most of the early appendicitis patients we see, we sent them home after a long-acting dose of an antibiotic with a prescription to finish total 10 days on oral antibiotics. And 90% of the patients we now treat, or who choose to be treated with antibiotics, we do send home from the emergency department. Surgeons all over the world have adopted this practice and offer that option to patients. Many even recommend it. But one place where they don't is the United States. And so surgeons have not adopted or routinely even talk to patients about the option of non-operative treatment. I think that's slowly changing, but we really lag behind our acceptance of what data is out there. And so along with colleagues at the University of Washington, we just completed the largest randomized controlled trial ever done. It was done at 25 sites in the United States, and I don't have the results yet, but in the meantime, as we're wrapping this up and conducting the remainder of the follow-up on the patients who are enrolled, you know, the COVID pandemic hit. And just yesterday, the American College of Surgeons, which had acknowledged non-operative treatment as a possible alternative for some patients, yesterday they came out with a recommendation that the treatment, the only one mentioned during the COVID pandemic, which they recommended, was non-operative treatment now. And so it may be that, you know, I mean, it's a good idea to try to keep people who don't need the hospital out of the hospital, but I think that was largely motivated by the concern for nosocomial transmission and acquisition of infection of surgeons themselves. So this will definitely change the conversation around the acceptance of non-operative treatment. I think you will see surgeons now who never had an opportunity to get experience doing this, because it does require some clinical experience and knowing how to do this and having confidence and feeling like you can treat the patient's pain safely. All those things we used to talk about before. I think more surgeons are going to start to get some experience with non-operative treatment, and this may be what sort of creates momentum towards that option becoming normalized.
Excellent. Look, we're going to wrap this up. There's a lot to talk about, probably with Amal and some other people soon, about the cardiac effects of COVID infections. We're getting some really concerning reports out of Italy that patients are presenting in frank shock, and that they're not dying from respiratory deaths, they're dying cardiac deaths. So we'll talk more about that with Amal, but just so you know, we are seeing that. And there is a lot of myopericarditis that appears to be occurring as well. I want to thank everybody involved in the front end and on the back end of all of this. Lots of people working really hard to get you this information. And to those of you that are out there seeing these patients under very trying circumstances, as always, thank you. You are doing the Lord's work. It's remarkable what is happening. And I like what I heard today, this idea from the governor in New York, that if this is going to be in waves, send New York all of the stuff right now, and then send it to California, and then send it over to Seattle. Makes a lot of sense to me. But again, thanks to everybody, and we'll post this so that if you missed any, it'll be up soon. Thanks, everybody.